Hi there, welcome to today's webinar, the COVID-19 Pandemic and Kids. My name is Jen St. Thomas, and I'm the Vice President of New Business Sales at Always Health Partners. I want to thank the Massachusetts Nonprofit Network for the opportunity to host today's session and for their leadership in the nonprofit sector, as well as for advocating on behalf of organizations that are helping to build strong communities across Massachusetts. At Always Health Partners, we have a longstanding commitment to our communities. As part of an integrated health system, Mass General Brigham, we have been focused on supporting all our customers and ensuring access to critical healthcare services throughout the COVID-19 pandemic, with guidance and support from the state. In that spirit, I'm pleased to introduce our speaker for today's session, my friend and colleague, Dr. Lael Yonker. Dr. Yonker is the director of the Pediatric COVID-19 Biorepository at Mass General Hospital, director of the MGH Cystic Fibrosis Center, and an assistant professor of pediatrics at Harvard Medical School. Since the outset of the COVID-19 pandemic, she has led the Pediatric COVID-19 Biorepository at MGH and has helped shape our understanding of how this virus affects newborns, infants, children, and young adults. She is currently investigating the impacts of viral load and immune responses in children with a COVID-19 infection, as well as the related inflammatory illness, Multisystem Inflammatory Syndrome in children. Finally, in August, Dr. Yonker co-authored an article in Time magazine addressing COVID in kids. One housekeeping item before we start: we will be taking questions at the end of the presentation, so please enter those in the Q&A section at the bottom toolbar. I'll now turn it over to Dr. Yonker for the latest on how the pandemic has been impacting our kids. Dr. Yonker?
Thank you. Thanks so much for inviting me. I'm happy to speak today about how kids have been impacted by the COVID-19 pandemic and how perhaps they've also been, more of a part of this pandemic than initially appreciated. So let's start next slide. As Jen mentioned, we've been really studying how the pandemic has impacted kids from the very beginning. And so going back to the very beginning dark days here in Massachusetts in March and April 2020, when we thought kids were actually spared from the pandemic, we came to the hospital when COVID cases were really high, and we just tried to collect samples from any child who had been exposed to COVID or was, did develop COVID, just to try to learn about our initial, goal was to understand why kids were doing so well as compared to the adults. And so this was a ton of work and continues to be a ton of work. But I have to say that this work would not be possible without support from nonprofits and foundations and philanthropists who really were able to allow us to have the manpower and the supplies to be able to get these samples. And we have had we've been able to build a huge understanding of how COVID affects kids, how kids contribute to the pandemic. And I'm going to touch on different areas of what we're learning and what we've been, contributing to our understanding, along with some other facts and sort of guidance, I guess, for COVID as we're going forward. But I just want to say that, nonprofit support, foundation support, philanthropy support is so critical to making those rapid steps. Of course, there's other ways, government funding, NIH funding. Those take a long time, and we wouldn't have been able to start up and get things running. I work closely with the OBGYN Biorepository, and they received funding from the March of Dimes. And so, and we received some philanthropy funding. So these things really allowed us to get started in the beginning. So next slide. And so what I'm going to talk about today is first, just, kids need masks. Why do kids need masks? In Massachusetts, we have it's a pretty universally accepted policy that, in schools, they're doing a great job. Kids need masks. This is not a universally accepted fact. So I just want to share a little bit of rationale as to why I say that. I'm going to talk about the Delta variant and sort of the concept of variants of concern. I'm going to give some information on vaccinations and boosters, which are more information is coming out, which is exciting, but also somewhat confusing. And then talk about this post-vaccination COVID-19 and what that means. And so lots to get through, and we'll try to go through things sort of quickly, and feel free to pass along questions as I'm going through. Next slide. So first, kids need masks. Kids need masks just as much as adults need to wear masks. So as I mentioned, we were collecting samples on kids who came in because of exposures. We've collected, now we've collected and cultured over 100 kids who've had some sort of COVID exposure or symptoms, or were hospitalized from COVID, either, just brief hospitalizations or, very sick hospitalizations. We've collected samples from everyone that we can, and we've compared with adults, and we've had our findings shared with the medical community. And basically this sort of dot plot that you see with the blue dots all over it, that are all over the place. There's no, trends. There's no rhyme or reason. Some are high, some are low across all ages. That's just showing us that all ages, the infants to the 22-year-olds, can carry very high viral loads, and very high viral loads, meaning live infectious viral loads, are probably up somewhere anything above 4. So all of those viral loads are quite high, quite infectious. And so age, even though the symptoms might be mild, the age does not impact how infectious a child can be. And these also, as I mentioned, are comparable to what we see in adults. And as I also mentioned, it does not matter with disease severity. So it doesn't matter if you're hospitalized or if you're as an outpatient, you can have just as much live virus in your airways. And we, I'm not going to go into all of the details here, but we do show that this is live virus and, transmittable virus. So, it's really important. As young as a child can tolerate a mask, they should be wearing them. Generally, the American Academy of Pediatrics recommends 2 years and above. Next slide. And not only is it important because kids can carry and transmit virus, but also if you have virus in your airway, or if a child has a virus in its airway, it's always trying to, viruses are trying to beat the system. That's just what they naturally do. They're always trying to get stronger, become more transmissible, and we've been seeing this. And so this is why we're watching these variants, and we're talking about variants. And so the more that a virus is circulating and is able to be sort of grow and spread for one person and grow and spread in another, changes can happen, and it's RNA in this case that can make it more contagious. And this just shows in this sort of phylogeny, this sort of line map in a circular fashion over here, you can see the black lines are adults and the red lines are children. You can see it, there's no patterns. The kids don't have a certain type of virus that's more mild. It's all the same. Sometimes those reds branch. And so you can see that there's basically, if there's virus in circulation, it's going to continue to develop variants. Some of them will be variants of concern, some of them will mean nothing. But if we allow virus to circulate among children without, realizing that it's circulating, you can sort of push variants to develop. And so we want to avoid that, not just for child and transmission, but really for global, to be able to control this pandemic. Next slide. And as you can see, the infections are on the rise, and this is the number of COVID cases in kids reported, detected. So probably early on, you can see on the far left of the graph, where the graph is near the lowest. That was, it was earlier in the pandemic when we just weren't testing kids as much. There were limitations and lack of recognition that kids could be infected with SARS-CoV-2. And then you can see the sort of seasonal peak last year around the holidays. And then the early summer was quiet. And then there's been this peak that's mirrored what we see in the adults, this summer peak that's really felt to be driven by the Delta variant along with other social and behavioral factors that are contributing, and certainly schools going back into session in certain states not requiring masks or requiring that you can't put a mask mandate in. Those have certainly contributed. And what I also want to point out is that all along, what we've been recognizing is that about 1% of kids with COVID do get hospitalized, and this is much lower than what you see in the adults. But that's what is reported by the American Academy of Pediatrics. And as you see this peak go up, we're going to see more kids getting hospitalized, and it's not necessarily a more deadly variant or anything. It's just a numbers game. The more numbers you have, the more kids that are going to get hospitalized as too, unfortunately. So next slide. So, and then some kids can get this very severe illness called Multisystem Inflammatory Syndrome in children. And this is a life-threatening illness. And next slide gives a little bit more detail. So basically you can see there's on the graph on the left, you can see this peak, this yellow peak of the first wave of the pandemic in the US. And then about a month later, you start to see these red bars tick up, and those are the MIS-C cases. So the MIS-C is a delayed inflammatory response. So it's this delayed severe illness where kids can get quite sick. This heat map on the right shows what it looks like. So in the top two bars is, the top bar is SARS-CoV-2 negative. So this is just a common cold. The middle row is SARS-CoV-2 positive, or kids with COVID. And you can see on those top two rows, there's very little difference. There's nothing that really shows one over the other. Just as likely to have fever or cough or stuffy nose, which makes COVID very challenging to detect in kids, especially kids who are in school or in daycare. And these are just facts of life. So it's challenging. MIS-C is distinct. So MIS-C is that bottom row. MIS-C, which is much easier to say than multisystem inflammatory syndrome. MIS-C presents with fever. Everyone has fever by definition, and very high fever, 102, 105, very high fever for a few days. And sometimes they get rash. Often they'll have GI symptoms like vomiting or diarrhea or belly pain. And then they can have some other just sort of vague symptoms. It's really non-specific. Next advanced slide. And so just to sort of show what's going on is, you start with COVID in the upper airways, and you clear it after, a week to 2 weeks. And kids, by the way, may even be asymptomatic during this time, or mildly symptomatic. They clear the virus from their airways and their nose. Weeks go by, and the virus sort of settles into the stomach, into the gut. And then you start to develop this fever, and you can ultimately develop heart injury. And some people end up even having to go on heart bypass support, and they can become quite sick. Next slide, or advance. And as of the summer, it hasn't been reported for over a few months, so I expect these numbers to go up fairly considerably, given that we've seen a recent peak. But there's been over 4,600 cases of MIS-C in the US. Now, all of these are quite sick. They get hospitalized, often requiring intensive care. And there have been 41 deaths to date. Next slide. And so part of what we've been doing is understanding why kids develop this really severe, unusual illness after they've had COVID. And so what I sort of explained, what happens, they have had COVID, maybe undetected mild COVID, maybe they had more symptomatic COVID. It doesn't really matter. They get over it, they clear the virus from their nose, but it settles into the gut. And we know it's in the gut because we have measured it and detected it in their stool. And then when the virus is in their gut, it tends to irritate the lining of the gut. And you release something called zonulin. And zonulin causes the tight barriers between that gut lining to loosen. And then you develop this leaky gut. And then the viral particles from in your gut can start to leak into your blood. And that is very inflammatory, and your body reacts very strongly. and you develop this hyperinflammatory response. And with this hyperinflammatory response, kids get very, very sick and end up requiring the hospitalization. Some of them end up having heart injury. Next, advance. And so what we've seen now, what we're doing to treat these kids who are very sick is we give them intravenous immunoglobulin, which is just generalized antibodies, not COVID specific antibodies, just sort of a generalized antibody to try to control the inflammatory response. And we also give them steroids. And they go on steroids for a long time, several weeks. And so these are very strong treatments to try to calm down that inflammatory response. And one of the things that we're doing based on what we've learned is if you advance, now we're trying to novel treatment to block the gut. And so this is something that we're doing at Mass General and expanding to other sites. But this is basically a treatment to try to, patch that leakiness so you don't have the trigger, and you don't, in theory, if you wouldn't need to be on quite as intensive immune suppression, and you'd be able to recover more quickly. And so this is something that we're looking into, and this is just something that is coming down the way. Next slide. So now I want to move on from sort of the general how kids are affected by COVID to the Delta variant. And the Delta variant obviously can impact all of us. And so as the virus changes over time, it makes these slight modifications. Some of them mean nothing. Some of them people are watching to see which way, if they're going to be more disease causing or not. But the Delta's really stood out from all of the prior variants because it's more infectious and it's more contagious. And you can see this is a slide off of the CDC that I took. And you can see for every one person with COVID that infects 2 individuals. And so now every one person with COVID infects 5 individuals. And so you're just much more likely to infect people, and the disease spreads more quickly. And you can see this, I took this from the prior slide from the American Academy of Pediatric numbers showing that this is just taking off in kids. And so we are plateauing now, though I anticipate with the holidays, starting with Halloween and Thanksgiving and the winter holidays, I think that we would expect to see transmission like we did last year, where we saw some peaks. So the Delta variant is definitely worrisome because of its transmissibility. Next slide. And so, as I sort of mentioned, the rates themselves, so it's 1% of patients with kids with COVID will be hospitalized. The rates are the same. It's not causing more, as far as the data that I've seen, it's not causing more hospitalizations as far as percentage, but the numbers are going up just because the number of kids infected are going up. And so, a certain percentage would develop severe illness requiring intensive care. And we're seeing more of it, again, just because the numbers are going up. The vaccines do, from all of the literature that I've seen, they are still effective against the Delta variant. But certainly it shows that doing what we can to reduce transmission is going to be important. So masks are really critical, especially indoors or in crowds. And of course, the CDC is monitoring closely for future variants. Next slide. So vaccination, I think this is, I was looking at prior slides and I used to sort of really focus on masks, and vaccination was sort of later, in the future, vaccinate when available. Now I actually think it's really important, and it's not, even if it's not available for kids or younger kids or youngest kids, it's still such an important topic because this is something that the community can really take on. And so if you're eligible for vaccination, you should vaccinate. And so it gets a little confusing as everybody's sort of going through this process at a different pace. So I have it here. This is off of the CDC. I double checked last night. So up to date, although one slight change as of this morning. So Pfizer or the BioNTech, which the brand name is Comirnaty, is the vaccine that most people have been vaccinated with in the United States. And it's now fully FDA approved for people 16 years and above, and it's under emergency use authorization for children 12 through 15 years. And when I wrote these, updated and double checked all the facts last night, the FDA was to review the vaccine for kids 5 to 11 on October 26th. But when I woke up this morning, I saw a notification that it's already been presented to the FDA and asked for approval. So things are moving more quickly than even, I hoped last night. And so this, I think, is something that we should be expecting very soon, likely to be implementable next month. And then there's Moderna, which is in emergency use authorization for individuals 18 and above, and the Johnson & Johnson's Janssen vaccine, which is an emergency use authorization for 18 years and above. And this one is not as common, but does have the benefit of being a one-shot vaccine strategy. Next slide. But the problem is if, vaccine effectiveness wanes over time. So there's a bunch of studies that show all, sort of without looking at individual studies, you can see that there's a downward trend, 4, 5, 6 months out after vaccine. And so the effectiveness is going down, and the effectiveness is just if you can carry the virus. It's not hospitalization or severe disease. And so this is showing that people over time are, if they're exposed to virus, are more likely to swab positive. Next slide. In contrast to vaccine effectiveness against hospitalization, which has mostly been staying flat, there are some downward trends in some of the studies, but for the most part, they're still quite flat, and that is reassuring. And I wanted to say that these studies include, you can sort of look into the details, but some are Moderna, some are Pfizer, but these are really focused on these mRNA vaccines. So this is a really good sign, because once you're vaccinated, you're very unlikely to develop severe illness. You're not, I'll talk about it in a minute, but it doesn't say that you'll never get COVID. Next slide. So boosters are coming out to address some of these issues. And so currently, if you've had a prior Pfizer series, and then you're eligible for a booster, if you're immunocompromised, if you're over 65 years old, or if you are 18 years or older and living or working in a high risk setting. And so all of the people, all of those first responders, or all of those sort of frontline workers who were in the vaccine phases early on, everybody in that age, in that category is eligible. Or if you have any of those underlying medical conditions like obesity or history or current smoking, or cancers, or any of those other underlying medical issues, then you would be eligible for a booster. So that's the vast majority of people, if it's been enough time out since your series. The patients who've had the Moderna series are not yet eligible for a booster. There is not one yet approved, although I would anticipate something coming in the near future. Next slide. And then one question that comes up a lot is this concern about safety. And this is absolutely a really important topic, because kids are generally mild if they get colds. If they get COVID. So if there's any risk to getting vaccinated, that's a real problem. And so there have been some reports of kids and adults developing myocarditis after they've had vaccine. And that's when the heart tissue is injured, and you start to see some sort of markers of injury in blood tests. And so on the left side, you can see the numbers of people who've developed myocarditis, and you can generally see they're all single digit or double digit, as compared to the numbers on the right of the slide. And those are individuals who've developed severe either hospitalizations, ICU admissions, or deaths, and they break them out by age group. So you can see sort of the top box is the 12 to 17-year-olds, the middle sort of boxes on either side are the 18 to 24-year-olds, and then below that are the 24 to 29-year-olds. And you can see the numbers are far greater in the COVID-related cardiac and other, complications as compared to the vaccine-related myocarditis. And so, the risk of developing myocarditis is roughly 1 in 200,000 across all individuals, young individuals. And then the risk of developing MIS-C, for example, is 1 in 1,000. And so, and there's a death rate associated with MIS-C. So I think that the risk is not nearly what you would expect from getting regular COVID. And we're in a pandemic. And if you can reduce your, contribution to the society, I think that that's another important factor that sort of takes away, is a separate issue rather than this, which is really that individual risk assessment. And so I strongly advocate for vaccination for kids. Next slide. And so to go over the summary, for vaccination, if eligible, so basically everybody over the years of 12 or 12 and older should vaccinate, in my viewpoint. And any, as soon, starting next month, anybody ages 5 and above should seek the mRNA vaccination. Then anybody who's eligible for the boosters should get that, so we can keep our immunity up over time. And lastly, the risk of vaccine myocarditis is much lower in this with the vaccine than what you'd see in COVID. So I just want to sort of restate that just to reassure people. Next slide. So now the question is, we're starting to hear in the news about this post-vaccine COVID-19, and that just sounds terrible. But you go through all this effort, you get the vaccine, and then you get COVID. First thing I just want to highlight is vaccination dramatically reduces serious illness, and that seems to stay fairly flat over time. It's not a zero risk, but it's fairly flat. And then it does reduce transmission. But that brings me to the next figure I want to show. And so this is a paper that's actually out. It's a preprint, so it has not yet been reviewed by the medical community. But this shows basically, the test results, or the viral load essentially, from individuals who had COVID, and they looked at who had had a prior vaccine and who had been not been vaccinated yet. And you can see there's no difference between the groups. And sort of counterintuitively, the lower it is on this scale, the more virus you have in your nasal swab. And so you can see just there's no difference. So you can have a lot of virus in your airways if you're not vaccinated or if you're fully vaccinated. If you could advance one more. And here they look to see if it depended on symptoms. Maybe you were, and these are all mild symptoms. These are not severe hospitalized patients, but symptoms. So the people who were fully vaccinated could get COVID symptoms, the respiratory, the fatigue, the fevers, and like the those who hadn't been vaccinated. But you can see, but what this slide is showing is that the viral load, there's no difference if you had those sort of symptoms. Next slide, or next advance. And same thing if you're asymptomatic. So we know that not everyone develops symptoms from COVID despite having a positive test. And this again showed that vaccine in this pretty large cohort didn't affect your amount of virus in your nose. Again, it's very clear that you're less likely to be hospitalized. So that's really important. But this shows that the vaccine is in your airways. It's not showing how long it's in your airways. And so other studies have shown that vaccinated individuals tend to clear the virus from your airways more quickly. So you have a shorter time period where you'd be carrying virus. And so then, therefore, in theory, a shorter time period where you'd be considered infectious. So that could play a role in reducing transmission. With this study does not look at, how their antibody responses were. So is there how long have they been out since their vaccine? Should they get a booster, or had they gotten a booster? Probably not, because the study just came out. And so I think that there's lots of questions here, but this shows that like a one-shot fix isn't going to make it so you'll never get COVID and you'll never have a positive COVID test. So that's important to consider. Next slide. And so sort of this is my last summary slide, because what do we do with all of this information? Things are changing. Things will continue to change. I think we have to keep an open mind. We have to continue to do our research. We have to continue to collect samples and pay attention to who's getting sick with what following COVID. But what we all can do is vaccinate ourselves, vaccinate our families as soon as everybody's eligible. And if a booster is available, to boost the immunity, then then we should do that. So I think whoever's eligible for a booster should get the booster. And importantly, if the community COVID-19 rates are high, then we should wear a mask indoors and in crowded spaces. Certainly that's the policy in Massachusetts now, and I think that's the right policy, but it's not everywhere. And I think that last slide I showed that this is probably important for those who are vaccinated as well as those who are unvaccinated. And leading into my next point, we have to remember those immunocompromised individuals, or those individuals who aren't eligible for vaccines, those young children who aren't going to be eligible for a while. And then the cancer patients who are on immunosuppression, or just the real elderly who can't generate quite the same amount of lasting immune response. So we have to be mindful of our entire community and our families, and we have to protect ourselves from developing COVID and transmitting it, even in a post-vaccine world. And so it's just something that, I think community rates are going to guide the guidance on that and help us decide where masks are needed or where they're not needed. But that's just something that I think is going to change over time. And then we have to do things like socially distance, wash our hands, do the important things to keep, augment the other, the masks and the vaccines. And most importantly, above all, I think we have to take care of ourselves, take time to take care of ourselves, support each other, be kind to one another, support the organization that you're part of, stay focused on your mission, and advance whatever, the cause that you're working on, whether it is related to COVID or things have been shown to be more of a problem because of COVID, or things are changing because of this pandemic, or just, we can't forget those important causes that we were all working on pre-pandemic. And so we have to keep things moving and sort of stay focused and working and supporting one another. And so with that, I just want to say thank you, and I'm happy to answer any questions.
Great. Thanks, Dr. Yonker. I think we do have a couple questions here. All right. So I think you had mostly covered this, but there was a question around if there's anything else that parents of children too young to be vaccinated can do besides masking. And sort of a related question is, for younger children visiting their grandparents, sort of what do you recommend?
Right. So, we showed that even if you're vaccinated, you can have COVID. You can test positive for COVID. So, generally, you could ask the grandparents if the grandparents are like post-vaccine, I'm living life again, I'm going back to normal, that is, we don't want to be held back. We all want to enjoy our lives. If that's sort of, they're hanging out with people who are all vaccinated and they're not worried, and they feel as though, that's great for them, but you have to be mindful that they could be, exposed to COVID or transmitting COVID. And so a really simple thing is to just have them do, a rapid antigen test before you visit. And so that's something that you could do to protect your child. Conversely, if they're worried or they're immunosuppressed or something, and they're worried, you could always do some swabs. And so generally the antigen tests, the rapid antigen tests are really good for just sort of low risk reassurance. And so that's something that you could do in addition to when you're, taking those general precautions, vaccinating everybody who's eligible and wearing masks when in sort of closer contact.
Great. We have another comment here. This is amazing info. Thank you. Which is so great to hear. Thank you, William, for your comment. Was the statistic that Delta is spreading to 5 people versus the previous variant was spreading to, they just couldn't recall, I think it was maybe 2?
2. Mm-hmm.
And then do you happen to have a comparable number for the flu or the Spanish flu, the previous pandemic?
I don't know off the top of my head. I just haven't been looking at the numbers recently, but it's a good point.
Yeah.
I think we're all well aware, though, that flu was non-existent last year because of masks. So that's a benefit too. And something, maybe it's not just going to be COVID that we're watching numbers for. Maybe it'll be flu and other things. And when we see, masks don't have to be a permanent part of our life every time we enter a building, but maybe we'll have a better understanding of risk assessment and what's there, that we would want to protect ourselves from. And so anyways, just something that's a good point, thinking about these other transmissible viruses.
Yeah. One of the other questions we had was around the symptoms in kids. And I know you had touched on it a little bit with Miss C, but, is a runny nose a reason to get a test for COVID? What would be your perspective?
Yeah, I would. So younger kids, you really can't tell. It's very frustrating. And right now there's a ton of viruses. It's like they all took a year off and now they're all back with a vengeance. RSV, paraflu, rhinovirus, it's all around right now. You can't tell the difference from those and from COVID. And so right now, any respiratory symptoms, even if you think they're allergies, you just have to get tested. And trust me, pediatricians are tearing their hair out because there's just so many people getting tested, but you have to, and you have to do it for your community, for the schools. And so anyways, it's hard, but yeah, I would say whenever you have those rapid tests on hand, and then of course, if you're exposed or have a higher concern for an exposure or think that you could have, your symptoms are really suggestive or a little more worrisome, then you should be seen and get a real gold standard PCR
test. Okay, great. And you do feel like the home tests are very credible to have on hand as sort of that first layer of protection?
Yeah, I do. There certainly, you can have false positives, you can have some false negatives. So I think if you get a test that doesn't really, so if you're asymptomatic, meaning having no symptoms, and you are have not been exposed, and an antigen sort of screening test is totally, before you go visit grandma or before you do something, is a great option. But if you have symptoms, or if you have been exposed to a close contact with COVID, then they're not as reliable.
Yeah, no, that makes sense. All right, I'm not seeing any more questions here, but we really appreciate your time, Dr. Yonker. This was so helpful and informative. I feel like I learned so much just attending this, so I really appreciate it.
Thanks for inviting me.
All right, and thank you to all the attendees. Appreciate it. Thank you.
Bye.
Bye.